Okay, shall we start? Oh, okay. So we'll start with peripheral nerve injuries now, and again a small basic anatomy about the peripheral nerves. See, when you see a nerve will have, you would have seen this diagram 1,000 times from your school days. Okay, so there is a cell body, and in that there is a nucleus. From the cell body there are small nerve filaments called as dendrites. Okay, and there is one long process, axonal process. This is called as axon, and this axon is covered by a sheath called as myelin sheath. Okay, so you would have known this, and this nerve goes and innervates a muscle. Okay, and this junction is called as, if this is muscle, this junction is called as a neuromuscular junction. This junction is called as neuromuscular junction. Okay, so this is a basic structure of a nerve and how it goes and innervates a muscle. So this junction is called as neuromuscular junction. Now, how a nerve is, see, this is a structure of a single neuron. Okay, this is a structure of a single neuron. Lot of neurons joins together to form a nerve. So when you make a cross section of the nerve, this is how you see. Let us consider this is axon. Okay, this is axon. This axon is surrounded by a sheath called as endoneurium. What is the sheath called as? Endoneurium. Lot of axons. Let us put lot of axons here. So lot of axons, they group together. Okay, this group is called as nerve fascicle or nerve bundle. Okay, and this entire nerve bundle is surrounded by a sheath called as perineurium. Okay, this is called as perineurium. Now the entire nerve fascicles, all the nerve fascicles joins together, and they form the nerve. So the entire nerve is surrounded by a structure called as epineurium. Okay, so whenever you see the coverings of a nerve, so there will be endoneurium, there will be perineurium, and there will be epineurium. What does endoneurium means? Endoneurium surrounds the axon. The axons all join together, group of axons joins together to form the nerve fascicle or bundle. They are surrounded by perineurium. Number of nerve bundles are held together by epineurium. Okay, so these are the coverings of a nerve. Now, nerve injury can happen at any point of these structures. So based on that, they classify the nerve injury into 3 categories by a person called a Seddon. So this is called a Seddon's classification. Nerve injuries are classified by Seddon. Seddon classified the nerve injury into 3 types. One is called as neuropraxia. Okay, neuropraxia. The next one is called as axonotmesis, and then last one is called as neurotmesis. Now what is called as neuropraxia? Here there is no anatomical discontinuity. There is only physiological stretching of the nerve. And this kind of nerve injury is seen in Saturday night palsy. Do anyone know what is called a Saturday night palsy? Yes, in Saturday night palsy, radial nerve is injured, or in condition like tourniquet palsy. After applying tourniquet for the limb, there can be nerve lesion. So this is called as tourniquet palsy. So in Saturday night palsy or tourniquet palsy, there won't be any anatomical disruption of the nerve, but there can be a physiological stretching of the nerve. Such a condition is called as neuropraxia. This is 100% recoverable. This kind of injury, there is 100% recovery is possible. And no Valerian degeneration happens. No Valerian degeneration happens. No Valerian degeneration happens. Okay. This is very, very important. Now, what happens in axonotmesis? See, in axonotmesis, only axon gets ruptured. Only axon gets ruptured. So, what is surrounding the axon? The endoneurium, perineurium, epineurium. So, all the sheaths remain intact. Sheaths remain intact. So, because the sheath remains intact, okay, axon can regenerate within the sheath. Axon can regenerate within the sheath, and they cause neuroma in continuity. They cause neuroma in continuity. Hence, this is also recoverable. Mostly this is also recoverable because only the axon gets cut. The outer tube is intact. So the axon can grow within the tube and the nerve can regenerate. So in axonotmesis, regeneration and recovery of the nerve injury is possible. Here, a process called as Valerian degeneration happens. Here, a process called as Valerian degeneration happens. Now, what is this called as Valerian degeneration? Valerian degeneration. Simple. See, just imagine the axon gets damaged here. Only here it is there, and the axon gets cut off here. Okay, clear? Now, the outer sheath is there. The axon gets cut off there. Now, the part of the axon which is distal to the ruptured part, this goes in for degeneration. This goes in for degeneration. This degeneration is called as Valerian degeneration. So whenever a nerve gets transected, the part of the nerve distal, or the part of the axon distal to the transected portion will degenerate. This is called as Valerian degeneration. Now after degeneration, new axon starts arising and it goes to the same area. This is called as regeneration. This is called as regeneration. Suppose, just imagine a nerve has got cut off in the elbow region. In the elbow region, a nerve has got cut off. So what happens to the remaining part of the nerve here? Here it has got cut off. What happens to the nerve here? It degenerates. So Valerian degeneration happens. Now from here, what happens? The nerve starts growing again. Okay, starts growing. So new nerve is started coming, and this new nerve growth occurs at the rate of 1 millimeter per day. 1 millimeter on the nerve. Okay, so the new nerve regenerates at the rate of 1 millimeter per day. And when, see, let us consider this is ulnar. Ulnar is running on the medial side, and it has got cut off here, and the rest part is degenerated. Now what you do is you tap the ulnar nerve force. The point where the regeneration appears, the patient will have a tingling sensation. This is called as Pinel sign. What is the sign called as? Pinel sign. So very simple. The nerve got cut off here. The nerve distal to the transected portion dies off. New nerve starts coming here. It grows at the rate of 1 millimeter per day. You tap the force of the nerve. At one point where the nerve is growing, you will have Pinel sign. You will have tingling sensation. After 10 days, you see, here it is now. After 10 days, how much centimeter it would have grown? After 10 days, how much centimeter it would have grown? 1 centimeter, 1 millimeter per day. 10 millimeter, 10 millimeter, 1 centimeter. So the Pinel sign will come here. After 20 days, after that, the Pinel sign will progress here. So this is called as progressive Pinel sign. What is this called as? Progressive. So all these are very important. Pinel sign is sign of nerve. Pinel sign is very important. It is a tingling sensation along the course of nerve regeneration. Along the course of nerve regeneration, and If it is progressive tinal sign only, the nerve is growing. Progressive tinal sign means it is growing, the nerve is growing. If it is not progressive, the nerve is not growing. Okay, so please remember this. Progressive tinal sign is very important. So in axonotomesis, you will have progressive tinal sign. Okay, clear? Now what happens in neurotomesis? Neurotomesis, a complete transaction of nerve. All the sheaths are gone, complete transaction. Let us consider this is a nerve bundle. Okay, it has got completely transacted. Okay, there is no sheaths are not continuous. Everything has got cut off. Now the axons which are growing here, they don't know where to grow. So they will grow here, they will grow here. Somewhere they grow. They won't grow distally here because entire sheath has got cut off. ஒரு டியூப் இருந்தாதான் அந்த டியூப்க்குள்ளார கரெக்டா வளர முடியும். Entire tube has got cut off. So the nerves it regenerate in a bizarre manner, and they form a nerve thickening. Okay, they form a nerve thickening which is called as end neuroma. End neuroma. So in neurotomesis, Valerian degeneration happens. Neuroma is an end neuroma, and tinal sign is non-progressive tinal sign is seen. Non-progressive tinal sign is seen. And this non-progressive tinal sign indicates that the nerve is not growing properly. So it requires surgical repair. Usually you take graft and repair. What nerve graft you take? Usually sural nerve graft or saphenous nerve graft you take to repair a damaged nerve. Now, there are three types of nerve injury: neuropraxia, axonotomesis, and neurotomesis. In neuropraxia, only physiological stretching of the nerve happens. No anatomical disruption, 100% recovery is possible. Whereas in axonotomesis, only axon gets cut off. The remaining sheath around the axon, you got endoneurium, you got perineurium, you got epineurium. If these sheaths remain intact, the nerve grows within the sheath, so the nerve regenerates properly. So you will have progressive tinal sign and no need for any surgery mostly. But in neurotomesis, the entire nerve gets cut off. The nerve does not grow where to go. They are pathless. They form an end neuroma, which results in non-progressive tinal sign. And it requires a surgical repair. Using a graft you can do. And that graft you can take either from sural nerve or from saphenous nerve to repair the nerve. Clear? So this is about the nerve injury classification. There is one more person called as Sunderland. He also classified the nerve injury. It's very, very simple classification again. Sunderland type 1 is like neuropraxia. There is no anatomical disruption. There is only physiological stretching. Type 2 is only axon gets disrupted. Type 3 is axon plus endoneurium gets disrupted. Type 4 is axon plus endoneurium plus perineurium gets disrupted. Type 5 is like neurotomesis. Okay, clear? So in Sunderland classification, there are five types of nerve injury. In type 1, it is like neuropraxia. In type 2, only the axon gets disrupted. It is like axonotomesis. It is like axonotomesis. Siddon's classification la axonotomesis paathom illaya, adu mari irukku Sunderland's type 2. Type 3 la vandu axon is get ruptured, endoneurium is get damaged. Type 4 la axon, endoneurium, perineurium has got damaged. And the fifth one, total nerve gets damaged. That's like neurotomesis. Okay, I hope you understand this. Yeah, simple, yeah, romba simple da, romba confused aganga. Oru diagram will explain you everything. This diagram illa. So you got the axon, endoneurium, perineurium, and the epineurium. The way how they get ruptured or torn, the classification goes like that. Okay, clear? So this is about the peripheral nerve classification. Specific nerve injuries. Okay, one is the first one to begin with is brachial plexus injury. Okay, brachial plexus injury, very, very important topic. So before going to the brachial plexus injury, first we'll see what is called as brachial plexus, how it is formed, then we'll go into the brachial plexus injury. See, brachial plexus is formed by the following nerve roots: C5, C6, C7, C8 and T1. Okay, it is formed by the following nerve roots, and the C5 and C6 nerve roots join to form the upper trunk. C7 continues as the middle trunk. C8 and T1 joins to form the lower trunk. Okay. Now what happens? This trunks divides into divisions, anterior division and posterior division. And the anterior division of the upper trunk and the anterior division of the middle trunk joins to form the lateral cord of brachial plexus. Joins to form the lateral cord of brachial plexus. Okay. The anterior division of the lower trunk forms the medial cord of brachial plexus. All the other three form the posterior cord of brachial plexus. Okay, simple. So brachial plexus is formed by C5, C6, C7, C8 and T1 root. C5 and C6 joins to form the upper trunk. The upper trunk divides into two divisions, anterior and posterior division. C7 continues as middle trunk. C8 and T1 joins to form the lower trunk. Okay, and they divide into respective divisions. So the lateral cord is formed by the union of the anterior division of upper trunk and the middle trunk. The medial cord is formed by the anterior division of the lower trunk. All the posterior cord joins to form the posterior division joins to form the posterior cord of brachial plexus. So this is simple of brachial plexus. Now there are a number of branches which arises from these plexus. We'll see what are the branches which arises. The main branches I will tell you. See, from C3, C4 and C5 a nerve forms, and that nerve is called as phrenic nerve. What is this nerve called as? Phrenic nerve. This phrenic nerve supplies diaphragm. Okay. Then from C5, C6 and C7 they form a nerve called as long thoracic nerve. Long thoracic nerve, which is also called as nerve of Bell. It supplies a muscle called as serratus anterior. If a brachial plexus injury occurs at the root level itself, please have this in your mind. If a brachial plexus injury occurs at the root level itself, so the long thoracic nerve will be affected. Serratus anterior will not work. This results in a scapula called as winging of scapula. So brachial plexus injury, if it is associated with a winging of scapula, which means the lesion is at a very higher level, close to the root, the injury has happened. Okay, very simple. Now coming to the upper trunk. From the upper trunk, you have got two nerves which are arising at this junction. One is called as the suprascapular nerve. The other nerve which is seen here is nerve to subclavius. The middle trunk and lower trunk, there are no branches. Which are seen at the middle and lower trunk. Only upper trunk gives two branches, suprascapular nerve and nerve to subclavius. Okay. Now from the divisions does not have any branches. From the cords, you got three. Okay. You can keep like this. Lata loves music. You can keep lateral pectoral nerve, lateral root of median nerve, and M stands for musculocutaneous nerve. And for medial cord, you can have this mnemonic: more money makes men unhappy. For first, M stands for medial pectoral nerve. Next stands for medial root of median nerve. M stands for medial cutaneous nerve of arm. Next M stands for medial cutaneous nerve of forearm. U stands for ulnar. For posterior cord, you can keep this mnemonic as ultra. Okay. U stands for upper subscapular nerve. L stands for lower subscapular nerve. T stands for thoracodorsal nerve. Thoracodorsal nerve. R stands for radial nerve. A stands for axillary nerve. So injury can happen in any of these areas, any of this plexus it can have injury. Now we'll see what are the main injuries in this region. So if an injury occurs in this junction, this is called as Erb's palsy. This will result in an injury called as Erb's injury, or it results in a palsy called as Erb's palsy. I'll take that shaded area alone separately and I will draw here. So C5 and C6 joins to form the upper trunk. This upper trunk divides into anterior division and posterior division. From the upper trunk, you get two nerves. One is called as a nerve to subclavius, and another one is the suprascapular nerve. So this point is the meeting point of 6 nerves. This is called as Erb's point. Okay, clear. Now the C5, C6 root mainly is seen in axillary nerve. Mainly it is seen in musculocutaneous nerve. These are the nerves which carries maximum of these fibers: axillary nerve, musculocutaneous nerve, and the suprascapular nerve. These three nerves carries most of the C5, C6 fibers. Now a damage has happened there, and these nerves will not work, which means axillary nerve supplies deltoid, which will not work. Musculocutaneous nerve supplies biceps and brachialis, which will not work. Suprascapular nerve supplies supraspinatus, which will not work. Now what happens now? Supraspinatus and deltoid muscle are the muscle which helps in abduction of the shoulder joint. If you want to lift your shoulder like this, supraspinatus and deltoid should work. If it is not working, you cannot abduct your shoulder. It goes towards the body. This is called as adduction. And if you want to flex the elbow, you need biceps and brachialis, which is not working there. So you cannot flex. So your elbow goes in for extension. Next is biceps is one muscle which supinates the forearm. Biceps is one muscle which supinates the forearm. Forearm on the, this is called as pronation, and this is called as what? Supination. When your palm faces forward, this is called as supination. When your palm faces backwards, it is called as pronation. Biceps is a muscle which supinates the forearm. It's one of the strong supinators. So please keep this in mind. Supinator ne or muscle irukku theriyuma? There is a muscle called a supinator, which is not the strong supinator. Biceps is the strong supinator. So you cannot supinate like this. The forearm automatically goes in for pronation. So the arm is adducted, elbow is extended, forearm pronated. This position is called as policeman hip receiving deformity. Policeman or weightless hip receiving deformity. Clear? Okay. So it is because of the involvement of C5, C6 nerve root. C5, C6 nerve root, most of the fibers goes to axillary nerve, musculocutaneous nerve, and suprascapular nerve. Suprascapular nerve mainly supplies supraspinatus, which helps in abduction. Axillary nerve mainly supplies deltoid, which helps in abduction. So that is lost. So it goes in for adduction. Musculocutaneous nerve supplies biceps and brachialis. So flexion is lost, goes in for extension. Biceps is again lost, goes in for pronation. So this type of deformity is called as policeman hip or weightless hip receiving deformity, which is seen in Erb's palsy. Erb's point is the point where the 6 nerves meet together. It's the point where 6 nerves meet together. Okay. So whenever an Erb's palsy happens, if it is an injury like this, you have to do an MRI. So where they do a brachial plexus screening, okay, and it can be treated with the splints like aeroplane splint. Aeroplane splint is a type of splint, so you use aeroplane splint to treat brachial plexus palsy. Sometimes it also requires surgery if the injury is very severe. If the injury is very severe, it also requires surgery. Okay. If suppose lower trunk of brachial plexus gets affected, lower trunk of brachial plexus get affected, then it results in a palsy called as Klumpke's paralysis. Klumpke's paralysis. Okay. Now, what is the lower trunk of brachial plexus? Just go back to the brachial plexus and see lower trunk how it is formed by C8 and T1. So C8 and T1 joins to form the lower trunk. And if you observe very clearly, the anterior division of the lower trunk, forms which cord? What is the main nerve of the medial cord? Ulnar nerve. So ulnar nerve is one nerve which is mainly affected in Klumpke's paralysis. So what is the trunk which is affected? Lower trunk. And how the mechanism of Klumpke's paralysis happens? See, sometimes a person falling from a height, if he want to save himself, he suddenly catch hold of something. So your shoulder goes in for abduction like this. So in that way, lower trunk of brachial plexus gets affected. So that results in a palsy called as Klumpke's paralysis. So in Klumpke's paralysis, what is the main structure which is affected is ulnar nerve. Ulnar nerve is getting affected. Now ulnar nerve is a nerve which supplies your intrinsic muscles of the hand. உங்களோட handல கூட குட்டி குட்டி muscles எல்லாம் சின்ன சின்ன muscles that it supplies the intrinsic muscles of the hand is supplied by ulnar nerve. When ulnar nerve gets affected, it results in a posture like this. It is called as ulnar clahan. It results in ulnar clahan, and also there will be decreased sensation along the medial 1.5 fingers. So there will be decreased sensation over medial 1.5 fingers, and there will be intrinsic muscle weakness leading to ulnar clahan. Okay, the patient can also suffer from Horner syndrome because T1 carries sympathetic fibers. In Horner syndrome, the patient can present with ptosis, drooping of eyelid, miosis, constriction of pupil, anhidrosis, loss of sweating, and loss of ciliospinal reflex and enophthalmos. So all these features are seen in Horner syndrome. So whenever there is Klumpke's paralysis, there is chances for Horner syndrome to happen together. Horner syndrome has got 5 components in it. Horner syndrome occurs because of the loss of sympathetic supply to the face. So it results in ptosis. Ptosis means drooping of eyelids. Miosis means constriction of pupil. Anhidrosis means loss of sweating. If there is no sympathetic innervation, there won't be any sweating. So loss of sweating is called as anhidrosis. Then you got loss of ciliospinal reflex and enophthalmos. Enophthalmos means sunking of eyelid. So sunken eyeball square தான் enophthalmos னு சொல்லுவோம். So all these are features of Klumpke's paralysis. So in a brachial plexus lesion, you can have Erb's paralysis or you can have Klumpke's paralysis. Okay. So with this, we will go into the next nerve injury topic, that is specific nerves we'll see. So first we'll start with axillary nerve. Okay. The axillary nerve is one of the important nerve around the shoulder joint. In the morning we saw shoulder dislocations or fracture of the proximal humerus can injure the axillary nerve. See, whenever axillary nerve is seen, you should remember about 2 things. One is the motor supply of the axillary nerve. Another one is the sensory supply of the axillary nerve. We have saw in the morning motor supply, it supplies deltoid muscle and it supplies teres minor muscle. Sensory, it supplies the regimental batch area. That is the upper lateral aspect of the shoulder, regimental batch area. So whenever an axillary nerve is injured, okay, so the deltoid muscle and teres minor will not work. So the patient will have weakness of abduction. Abduction weakness occurs. abduction weakness occurs. Teres minor cause weakness of external rotation. Weakness of external rotation. Weakness of external rotation. Okay. Sensory loss result in regimental batch area anesthesia. So there will be loss of sensation in the regimental batch area. So axillary nerve injury will present with all these things. Clear? The next nerve which is injured in the shoulder region is musculocutaneous nerve. Musculocutaneous nerve. Musculocutaneous nerve injury can also occur because of shoulder joint dislocation. The motor supply for musculocutaneous is, what are the regions supplied by musculocutaneous? Motor supplies to coracobrachialis, which is a weak flexor of the shoulder. Then biceps, which is a strong supinator, which will become weak. And brachialis, which is a flexor of the elbow joint. So all these things will be affected. Flexor of elbow. So the patient with a musculocutaneous nerve will have weakness of elbow flexion. He will not be able to supinate the forearm, and there will also be weakness of shoulder joint. Sensation. See, musculocutaneous nerve continues as lateral cutaneous nerve of forearm. Lateral cutaneous nerve of forearm. Okay. So if you take the forearm, so this is forearm, thumb, then this is the fingers, this is the little finger side, ulna side. So this is the thumb side. So the lateral cutaneous nerve of forearm supplies the lateral aspect of the forearm. So there will be decreased sensation in the forearm on the lateral side because of musculocutaneous nerve injury. Clear? Musculocutaneous nerve injury, it causes decreased sensation over the lateral aspect of the forearm. Okay, so this happens when there is a musculocutaneous nerve injury. Now we'll go into the next nerve injury, that is median nerve injury. Median nerve injury. From this, certain points are getting very important from median nerve, ulnar nerve, and radial nerve. Lot of questions are repeatedly asked. So we'll see what are the muscles which are first supplied by median nerve. In the forearm, median nerve supplies pronator teres. It supplies flexor carpi radialis. It supplies flexor digitorum superficialis. It supplies palmaris longus. It supplies all these four muscles in the forearm. Along with that, it also supplies the lateral half of flexor digitorum profundus. It also supplies flexor pollicis longus. It also supplies pronator quadratus. So these are the muscles which are supplied by the median nerve. Median nerve supplies most of the muscles of the forearm. The muscles of the forearm helps in doing heavy activity. That is why median nerve is also called as laborer's nerve. That is why median nerve is also called as laborer. If you want to lift a heavy weight, you require all the forearm muscles to act. So most of the forearm muscles are supplied by the median nerve. So median nerve is also called as laborer's nerve. It is also called as laborer's nerve. Laborer's nerve. Clear? Now in the hand, the median nerve supplies thenar muscles. Median nerve supplies thenar muscles. What are the thenar muscles which are supplied by median nerve? Abductor pollicis brevis, flexor pollicis brevis, and opponent's pollicis. There is one muscle in the thenar group not supplied by median nerve, that is adductor pollicis. Very, very important. MCQ repeatedly asked. Adductor pollicis is supplied by ulnar nerve. Adductor pollicis is supplied by ulnar nerve. Though it is thenar muscle, adductor pollicis is supplied by ulnar nerve. Okay. In addition to this, the median nerve also supplies the first and the second lumbricals. First and second lumbricals. Okay, clear? Now coming to the sensation. Sensory supply. Median nerve supplies the following areas. Let us draw the median nerve region in the hand. So this is hand, this is the lateral side, and this is the medial side. Median nerve supplies the lateral 3.5 fingers. The median nerve supplies lateral 3.5 fingers. So this much is supplied by median nerve on the palmar aspect. Okay. So on the dorsal aspect, so I'm turning the hand now. On the dorsal aspect, you will see the nail buds. So up to the nail buds, okay, it is supplied by median nerve in the lateral 3.5. So these are the areas, sensory supply. Please remember, the green color area, shaded area shows the sensory supply. Okay, clear? So these are the areas which are supplied by the median nerve in the fingers. And in the hand also, the medial half, the lateral half is supplied by median nerve. The lateral half is supplied by median nerve in the hand also. On the palmar side, it is supplied by median. Now just imagine the median nerve has got injured. Okay, it can get injured either at the wrist level or it can get injured at the forearm, elbow level. It causes paralysis of these muscles accordingly. It causes paralysis of these muscles accordingly. To enhance few things, I'll tell you very few points related to median nerve injury so that you can understand the injury of the median. In the wrist or in the hand region, the three muscles which are supplied by median nerve is one is abductor pollicis brevis, flexor pollicis brevis, and opponens pollicis brevis. In the morning I told you this is called as what? Abduction. And this is called as what? Flexion. And this is called as what? Opponents, opposition. So these three actions will be lost. So the patient will not be able to do abduction, the patient will not be able to do flexion, or it becomes weak actually, and he will not be able to do opponents. So what happens? The thumb will not lie separately. It goes and lie in the same plane as the other fingers because it cannot abduct. It goes and lie in the same plane. Because of this, it results in a hand called as ape-thumb deformity. It results in a hand called as ape-thumb deformity. If you need a monkeys, thumb தனியா இருக்காது, மற்ற ஃபிங்கர்ஸோட சேர்ந்து இருக்கும். So அந்த மாதிரி இருந்ததுன்னா that is called as ape-thumb deformity. Because abduction is not working, adductor pollicis is working. Because adductor pollicis is supplied by ulnar. So it goes in for adduction like this. So this is called the ape-thumb deformity. This is first thing. So if you see ape-thumb deformity in the hand, then it indicates what nerve injury? Median nerve injury. This is first one. Next is the median nerve supplies the lumbricals in the hand. What are the lumbricals which are supplied by median nerve? 1 and 2. If the lumbricals are not working, the fingers goes in for clawing. It goes in for clawing. So this is called as claw hand. This is called as claw hand. So median nerve injury can cause clawing. The third one is if the median nerve gets injured at the elbow. For example, it gets injured at the elbow. What are the muscles which are supplied by the median nerve in the forearm? All the muscles, most of the muscles. The important muscle is flexor digitorum superficialis and profundus. The fingers are clear. If you want to flex your fingers, flexor digitorum superficialis and flexor digitorum profundus is important. If you want to flex your fingers now, flexor digitorum superficialis, flexor digitorum profundus is important. The ரெண்டு muscle, flexor digitorum superficialis is completely supplied by median. Flexor digitorum profundus is supplied by flexor digitorum profundus என்ன ஆஃப் சப்ளை பண்ணுதுன்னு சொல்லுங்க? Lateral off. So flexor digitorum profundus for this finger and this finger is supplied by median nerve. For the ring finger and the little finger is supplied by ulnar. So ulnar intact ஆ இருக்கு. Median nerve போயிடுச்சு. அப்ப flex பண்ணும்போது you will be able to flex these fingers. இது ஓரளவுக்கு முடியும் because கொஞ்சம் கனெக்ஷன் இருக்கும், but this he cannot do. So the finger keeps like this. So this is called as pointing index. புரியுதுங்களா நான் சொல்றது? If you want to flex your fingers, you need FDS and FDP. Flexor digitorum superficialis and flexor digitorum profundus is important. lateral half of flexor distal profundus மட்டும்தான் median supply பண்ணுது. Medial half of flexor distal profundus is supplied by ulnar. So you will be able to flex this finger. The tendon connection இருக்கிறதுனால இது ஓரளவு bend ஆகும். This won't bend, so it keeps pointing towards. This is called as pointing index. It is also called a sign of benediction. Fathers only இப்படி வச்சு தானே ஆசீர்வாதம் பண்ணுவாங்க. So this is called a sign of benediction. So if you see sign of benediction, if you see pointing index, if you see eighth thumb deformity, then all these are diagnosis of which injury? Median nerve injury. Okay, now for the thing, give me the pen. See, you keep the pen over the palm. Ask the person to touch the pen like this with his thumb. What is this action called as? Abduction. Will he be able to do abduction or not? Now this is called as pen test. What is this test called as? This is called as pen test. So pen test is also diagnostic of median nerve injury. Okay, so these points you should take. So what are the tests you do? One is the pen test, then is eighth thumb deformity, then pointing index, then sign of benediction. All these are evidence of median nerve injury. And in which part of the fingers you will not have sensation? Lateral 3 end of fingers you will not have sensation. This is about the median nerve injury. Okay, fine. Next we'll go to the next topic, ulnar nerve injury. Few important points in ulnar nerve injury. Ulnar nerve supplies the muscles in forearm. What are the muscles which are supplied by ulnar nerve in forearm? One is flexor carpi ulnaris, another one is medial half of flexor digitorum profundus. Only these two muscles ulnar nerve supplies in the forearm. It does not have major contribution in forearm, but it supplies most of the muscles in the hand region. Now in the hand region, ulnar nerve supplies the following muscles. It supplies all the hypothenar muscles. Okay, it also supplies adductor pollicis. It also supplies the third and fourth lumbricals. And it also supplies the interossei. Interossei are two types. One is called as palmar interossei. Another one is dorsal interossei. Okay, clear? Fine. So we'll start one by one. So first we'll see about the problems. Okay, sensation will finish. So this is about the sensory part of the ulnar nerve. You all know ulnar nerve supplies the lateral medial 1.5 fingers. Okay, and the medial side of the palm. And when you turn the hand dorsally on the posterior aspect, where you can see the nail buds, again ulnar nerve supplies the entire fingers on the dorsal aspect also. This is the sensory supply of the ulnar. Okay, this is the sensory supply of the ulnar. Now we'll talk about certain tests to diagnose ulnar. First is, see, ulnar is one muscle which supplies the lumbricals, third and fourth lumbricals also. So normally what is the action of lumbricals? When you take the lumbricals, you should remember like this. If you draw a line like this, it comes in which letter? Letter L. L stands for lumbrical. This is the action of lumbricals. Now what joint is this? Is metacarpophalangeal joint, and these are intraphalangeal joints. So when lumbricals work, you will have flexion at the metacarpophalangeal joint and you will have extension at the intraphalangeal joint. This flexion, the metacarpophalangeal joint is in flexion, intraphalangeal joint is in extension. If the lumbricals are not working, opposite happens. Metacarpophalangeal joint goes in for extension, intraphalangeal joint goes in for flexion. This is claw hand. It's like a bird's feet. Yeah, so this is a claw hand. Normal lumbricals work for it now. You will have flexion at the metacarpophalangeal joint and the extension at the intraphalangeal joint. The opposite happens. This is called as claw hand. So ulnar mattu work agana, it results in ulnar claw hand, because ulnar supplies how many lumbricals? Third and fourth lumbricals. So the third and fourth complicals the run finger motor goes in for clawing. So this is called as ulnar clawing. This is called as ulnar clawing. This is first thing. Next, the ulnar supplies the muscle called as palmar interosseous. So there are 4 palmar interosseous. Very simple. The action of palmar interosseous, PAD, palmar interosseous, pad now. Palmar interosseous causes adduction. Palmar interosseous causes adduction. Okay. So P for palmar interosseous, AD for adduction. So you can keep this mnemonic as adduction. What is called as adduction in the hand? The shoulder adduction enna pagum? You move your hand, arm towards your body. This is called as adduction. Yeah. So, nammaloda shoulder on the axis on the midline of the body, which is running to the midline of the body. So when you move your limb towards the midline of the body, this is called as adduction. When you move your limb away from the midline of the body, this is called as abduction. This is called as abduction. For the fingers, the axis runs through the middle finger. Middle finger oda axis goes. Appo in the axis la irundhu na fingers velila kondu pona enna? What is this called? This is called as abduction. And you move your fingers towards the axis. This is called as adduction. So in the movement pair enna? Adduction. Idukku pair abduction. It's very simple. So this is adduction and this is abduction. Now you ask the person to take a card like this and you hold it between the fingers like this and you try to pull it. Okay, the 2 fingers, if it adducts, the card will not come out. If it cannot adduct, the card will come out. This is called as card test. This is called as card test. So run the finger, ungala adduct panna mudiyadha, the card you can hold it nicely. So this is called as card test. Okay. Now next is you ask the patient to keep the hand over the table and you ask him to abduct the fingers, or you ask him to take the middle finger above and move on either side. If he cannot do this, then his abductions are not working. Abductors are not working. Abductors either being for the dorsal interosseous. DAB, D-A-B, DAB. Dorsal interosseous, D stands for dorsal interosseous. A-B stands for abduction, DAB, abduction. So if he cannot abduct or if he cannot lift his middle finger and abduct on either side, then that test is called as Igawa's test. What is this test called as? Igawa's test. Igawa's test is the diagnosis of ulnar injury. Ulnar injury diagnosis is one of the methods. Then there is another muscle called adductor pollicis. Adductor pollicis. This is action. What is this action of thumb called? What is this action called? Abduction. What is this action called? Abduction. Give me this. See, I ask the patient to hold the notebook between my palm and the thumb. So now, if I want to hold this, my adductor should work. Adductor pollicis work pananum. Appo note vandu enala the thumb la pidikka mudiyum. Yeah, if I want to hold the note with my thumb, my adductor pollicis should work. Adductor pollicis supply to which nerve? Ulnar. Ulnar is called camel. Will the adductor pollicis work or not work? It will not work. Now when I try to pull this note, the patient will do a movement like this. He will flex the thumb and he will try to hold. The thumb வந்து flex பண்ணி இந்த நோட்டை பிடிக்க ட்ரை பண்ணுவார். சரியா? Why he is flexing? He is flexing the thumb to hold the note. The flexion of the thumb is produced by a muscle called as flexor pollicis longus. What is that muscle called as? Flexor pollicis. Flexor pollicis longus is supplied by median. So median of injury inga illa. Only ulnar nerve injury is there. So when you try to pull the note, he flexes the thumb and he tries to hold the note. This sign is called as Frohman's sign. The sign is called as Frohman's sign. So 3 important tests. One is card test. One is card test. To check the palmar interosseous, Igawa's test. To check the dorsal interosseous. The last one is Frohman's sign. Frohman's sign to check the adductor pollicis muscle. Adductor pollicis muscle. Okay, I'm just highlighting only the important test. I'm not going to the each and every muscle per se. These are important exam points, so I'm just highlighting only these things. Okay, and you will also have loss of sensation over the medial 1.5 fingers, both on the palmar and the dorsal aspect if there is an injury. Okay, clear? So this is about ulnar nerve injury. There is an entity called as ulnar paradox. Ulnar paradox nu or entity irukunga. I'll just tell you what is called as an ulnar paradox. Just take this word in your mind. Normally, whenever a nerve lesion occurs higher up, okay, the deformity will be very severe. If a nerve lesion occurs higher up, the deformity will be very severe. But in an ulnar nerve, higher the lesion, the deformity is less. Okay, this is called as ulnar paradox. Paradox na normal mari nadakarada ulnar paradox. Okay, so higher the ulnar nerve lesion, less the deformity. So that is called as ulnar paradox. That is called as ulnar paradox. Okay, fine. So the last nerve in the upper limb to be discussed is radial nerve injury. Radial nerve injury. Okay, before going into the radial nerve injury, we'll have to see a small course of the radial nerve. So let us consider this is the humerus bone that ends in the lower side. So you have the radius and you have the ulna here. Now the radial nerve comes from the posterior cord, passes through a space called as the quadrangular space. Inga or space irukunga, that space is called as sorry, just a second. So the radial nerve runs here, passes through a space called as lower triangular space. Lower triangular space, and the nerve runs through the spiral groove, comes to the lateral side, okay, runs here anterior to the lateral condyle and then divides into two. Okay, so the radial nerve divides at the neck of the radius into two. One is the posterior interosseous nerve, which is called a spin. Another one is the superficial branch of radial nerve. Superficial branch of radial nerve. Okay. So the radial nerve is coming from the axillary region, passes through the lower triangular space, runs through the spiral groove, runs on the anterior aspect of the arm, and then it enters the elbow and divides into two in the cubital fossa. One branch is called a spin, which is called as posterior interosseous nerve. The other branch is called a superficial branch of radial nerve. Now we will see what are the motor supplied by this nerve. See, in the axilla, in the higher up, radial nerve supplies long head of biceps. Long head of triceps. Radial nerve supplies long head of triceps. In the spiral groove, it supplies the medial head. It supplies the medial head and the lateral head of triceps. Below the spiral groove, it supplies brachioradialis, extensor carpi radialis, longus. In the spiral groove, it also supplies one more muscle, that is unconeus. Now, after dividing into two branches, the posterior interosseous nerve supplies all the other muscles of the forearm. All other muscles are supplied by posterior interosseous nerve. Superficial branch of radial nerve, no motor supply, only sensory supply by superficial branch. This is only sensory, no motor in this. Okay. Now we will analyze one by one. Triceps muscle causes what? Triceps muscle is an extensor of elbow. If you want to extend the elbow, triceps has to work. Triceps is here. If it contracts, you will extend the elbow. In a very similar way, wrist. If you want to extend the wrist extensor should work. One wrist extensor which is seen here is extensor carpi radialis longus. Extensor carpi radialis longus muscle will help in wrist extension. Ella muscle, other muscle will also help. But one muscle which helps here is extensor carpi radialis longus. Pin muscles, the muscles which are supplied by the pin, post interosseous nerve supplied from the muscles, will cause extension of the fingers. Now, suppose if an radial nerve gets injured at this level, pin alone gets damaged. Abhina, what is the thing which the patient cannot do? He cannot extend his fingers. So this is called as finger drop. So only finger drop means which means only pin is the nerve which has got injured. Post interosseous nerve mattum injury. If he cannot extend his fingers. if he cannot extend his fingers and if he cannot extend his wrist. So both finger drop plus wrist drop, which means there is an injury to the nerve. So radial nerve has got injured below the spiral groove. Below spiral groove. Now he cannot do wrist extension and finger extension, and the elbow extension has become weak. Elbow weak ayiduchu. Elbow extend pandrathu weak ayiduchu. Abdina, so there is finger drop plus wrist drop plus there is weakness of elbow extension. That means injury is above the spiral groove. Injury is above spiral groove. If all the things are lost, injury is in the axilla. In the axilla. Can you able to understand this? Muscle inga supply pandradhu neenga paathirpeenga. So it occurs like this. So depending upon the lesion where it happens, the radial nerve will have its manifestation. So just a small recoil. If I cannot extend my finger, posterior tarsus nerve is got damaged. If I cannot extend my finger and if I cannot extend my wrist also, both wrist and fingers drop, then it indicates lesion is below the spiral groove. I can't do this, and my elbow extension is also weak, which means it is at the level of spiral. If I can't extend the elbow also, my elbow goes in for flexion, lesion of the radial nerve is at a higher level. Lesion of the radial nerve is at a higher level. See, all these points are very important. This based on these things, many times questions have been asked. So please read well in these areas. Okay, so this is about the nerve injuries of the upper limb. Okay, this is about the nerve injuries of the upper limb, and we will also see about the nerve injuries of the lower limb. Yes, so with that we will finish. Injuries of nerves of the lower limb. One important nerve is sciatic nerve. Sciatic nerve. In the morning we saw posterior dislocation of the hip causes sciatic nerve injury. Okay, so sciatic nerve has got two components in it. One is tibial part and another one is common peroneal part. Common peroneal part. Okay, see if these nerves gets affected, if sciatic nerve gets affected, the muscles which are supplied by the tibial part and the common peroneal part will all go in for paralysis of the lower limb. More than sciatic nerve injury, common peroneal nerve injury is very frequent. So we will just have a detailed review of common peroneal nerve injury. Common peroneal nerve divides into two nerves. One is called as deep peroneal nerve, and another one is called a superficial peroneal nerve. Superficial peroneal nerve supplies the muscles on the lateral compartment, muscles of the lateral compartment of the leg. Those muscles are peroneal muscles. Those muscles are peroneal muscles. These peroneal muscles are everters of the foot. What they are? They are everters of the foot. So this is very important. And it also supplies skin over the dorsum of the foot. Skin over the dorsum of the foot. If you draw a foot like this, so this is the dorsum because you can see the nail beds. Most of the region is supplied by the superficial peroneal nerve. Most of the region is supplied by superficial peroneal. Deep peroneal nerve supplies tibialis anterior, extensor hallucis longus, extensor digitorum longus, and peroneus tertius. These are the four muscles which are supplied by the deep peroneal nerve. And this part of the skin, that is the first web space, is supplied by deep peroneal nerve. The first web space is supplied by deep peroneal nerve. Okay. Now just think, if common peroneal nerve has got damage, what are the nerves that is not working? Deep peroneal nerve will not work. Superficial peroneal nerve will not work. What are the muscles which are supplied by deep peroneal nerve? These are the muscles. Now, what is this muscles and what are they do? The muscles on the anterior compartment of the leg, when they contract, the foot goes in for dorsiflexion. Okay, and when the muscles on the lateral compartment of the foot contracts, the foot goes in for eversion. If these muscles are not working, opposite happens. The foot goes in for plantar flexion and inversion. Okay, this is called as talipus equinovarus. Talipus na ankle, reversion na equinus, equinus. The foot is inverted. This is called as inversion. Medial side rotate or inversion. Okay. So in a common peroneal nerve injury, the patient will present with the attitude like this. We can also call this as foot drop. We can also call this as foot drop because he cannot lift his foot. The foot has dropped like this. Okay. So in a common peroneal nerve injury, the patient can have talipus equinovarus deformity because of the loss of power on this muscle. Okay, clear? So this is about the common peroneal nerve injury. Now, whenever a nerve is injured, okay, you can diagnose a nerve injury by using a study called as nerve conduction study. You can do nerve conduction velocity study to identify the nerve injury, or you can do electromyogram to study the nerve injury. Electromyogram to study the nerve injury. Whenever a nerve has got injured, initial stages, if it is an neuropraxia or an axonotomesis kind of injury, you can wait and watch. You can give physiotherapy and you can give splints for the patient to keep the limb in functional position. For example, what is this hand called as? Ulnar hand. To keep the ulnar hand in functional position like this, you can give a splint called as knuckle bender splint. Knuckle bender splint is given for ulnar nerve palsy. Okay. So what is this drop called as? Wrist drop. Wrist drop is seen in which kind of nerve injury? Radial nerve. So to keep the wrist in position, you can give cock up splint. You can give cock up splint. Okay. So by giving these splints, you can keep the parts in functional position. You can keep the parts in functional position. You can train the muscles for physiotherapy. If the nerve is not recovering, then we plan for a nerve repair or a tendon graft we do. Okay. All this has to be, if the nerve repair has to be done, it has to be done at the earliest. If after 2 years, even if you do nerve repair, there is no use. After 2 years, if you do nerve repair, there is no use. If you have to do nerve repair, you have to do before that. Okay, clear? So these are the various splints which are used in the nerve injuries, and these are the important nerve injuries which we see commonly. Okay.